First question, which is the most commonly fractured bone of the facial skeleton? The answer is nasal bone. Nasal bone is the most commonly fractured bone of face. Look at the skull. Now, this bone, pair of bone, right side and left side, this is a very thin cosmetic bone and very easy to get fractured. So there will be history of trauma. Somebody punched the nose or got hit with the cricket bat or some accidental injury. There is certainly injury given over there. What's the clinical scenario? After trauma, the nasal deformity. Trauma causing nasal deformity is a nasal bone fracture scenario. My dear friends, always read like this, not like a theoretical paper. How to crack the clinical vignette. Nasal trauma causing deformity of nose, think of nasal bone fracture. There may be crepitus written over there. When you move the fracture fragment, there will be click, click, click kind of sound over there. Plus minus swelling, edema around the nose, which will be there after 1 or 2 days, not immediately. So this swelling is plus minus. You are the intern, somebody had an accident, he came to the emergency, there is a deformity of the nose. What test would you recommend? Of course, X-ray nasal bone, right lateral view and left lateral view. X-ray nasal bone, right and left lateral view. Just look at this white arrow. Now, this white arrow shows the discontinuity in the nasal bone. So the fracture is confirmed on the X-ray also. You will call me, the ENT surgeon, will come. We take the patient to operation theatre, and what we do over there, we do the nasal bone fracture reduction. Now, is it open reduction or close reduction? Definitely, it's close reduction. You can see in the picture also. We are just holding the fracture fragment with the forceps and bring it back to the original position. Now, there is a forceps name you need to remember. The name of forceps is Walsham forceps. So, the treatment is closed fracture reduction of the nasal bone using which forceps? Walsham forceps. Okay. Now, my dear friend, this is the Walsham forceps being used. The one prong inside the nasal cavity, one prong on the skin, and you manipulate the bone back to the original position like this. See the video clip. This is the Walsham forceps. Now, the question asks is, what is the best time to reduce the nasal bone fracture? My dear friend, nasal bone is a cosmetic bone. Now, there can be two scenarios given to you. One scenario is no swelling. No swelling. The other scenario is they say there's swelling around the nose present. Now, if no swelling is given in the question, then the procedure should be done immediately. It should be immediate closed fracture reduction. But if they say swelling is present, patient came after 1 day, edema is there, swelling is there, then the answer will be wait for 7 days to let edema subside and then do the closed fracture reduction. Procedure will remain same, forceps will remain same, the timing of the fracture reduction will be different. If scenario A is given, no swelling is mentioned, then the answer will be immediate closed fracture reduction using Walsham forceps. And if scenario B is given, that nasal deformity with swelling is given, then answer will be wait for 7 days and then do the closed fracture reduction. Why wait for 7 days? Let edema subside. Why edema is important here? It's a cosmetic bone and you want perfect correction of the nasal skeleton. Because this is, people are very touchy about, because the Snapchat, they want perfect noses, So that's why this is a very delicate thing, we have to be very careful because patient will ultimately be not satisfied. Now, after you fracture reduction, then you put a cast. It may be a POP cast or aluminum cast just for, 7 to 10 days to stabilize the nasal bone over there. The second traumatic entity I would like to talk to you about will be septal hematoma. Trauma to nose can lead to nasal bone fracture also, septal hematoma also. My dear friend, septal hematoma is a bilateral entity. You can see over here, there's a bilateral swelling of the septum. Okay, so trauma history will be there, and after trauma, there'll be bilateral nasal obstruction. So MCQ is very beautiful. Trauma to nose. They may say the child was cycling in the garden, he fell down, or they were playing cricket and somebody hit the nose with the cricket bat. trauma causing bilateral nasal obstruction. Trauma causing bilateral nasal obstruction is a clue for septal hematoma. Okay. Now, plus minus swelling can be there around the nose. Okay. Now, what is the treatment of septal hematoma? Don't waste time. Treatment will be take the patient to operation theatre and do IND. What is IND? Incision and drainage. Give a septal incision, drain the hematoma, or you can go for aspiration. Put a needle and suck the hematoma out, and after that you put the tight pressure pack, anterior nasal packing on both sides like this. So that's the treatment of septal hematoma. If you don't drain the septal hematoma immediately, it will lead to septal abscess formation. And septal abscess will convert to septal perforation because abscess will eat away the septal cartilage. So septal hematoma should be either aspirated or drained. Don't leave it like that. It will convert to septal abscess and that will lead to septal perforation. Now let us be clear about two clinical vignettes related to trauma. If trauma to nose leads to nasal deformity, then think about the nasal bone fracture question. Deformity is there. But if trauma to the nose lead to bilateral nasal obstruction, then think of septal hematoma. So both are question. Trauma causing deformity of the nose, nasal bone fracture question. Trauma causing bilateral nasal blockage, septal hematoma question. And septal hematoma should be drained immediately. You don't leave it like that. It can destroy the septal cartilage and the shape of the nose may be destroyed permanently. It happened to one of my friends, another ENT surgeon, operating in the same ENT OT. It was his birthday and he finished his OT and he came to my OT table. He said, Rajiv, hurry up. Let's go to the mall for lunch, birthday lunch. We went to the mall. Malls are super clean nowadays. You know, there are glass gates. They are so clean, the glass is not even visible. This gate had two doors. One door was open, other door was still closed. I passed to the open door and the birthday boy passed to the closed door. And he smashed his head into the glass gate. And suddenly he got difficulty breathing both sides. Septal, beautiful hematoma. Then no lunch. I brought him back to the same operation theatre where he operated the last case, same OT table where he operated the last case, and I drained the hematoma, put the pack over there, and I said, happy birthday. So in septal hematoma, don't waste time because it can lead to septal abscess. My dear friends, let us go to the third topic of nasal trauma, nasal septum fracture. So nasal trauma can lead to nasal bone fracture, septal hematoma, and the third one is nasal septum fracture. Now, this fracture is of two types. It depends how the injury happened to the nose. What was the direction of impact? My dear friends, look at the picture number A. If the force is from front, it will lead to horizontal fracture. You see, septum is like this. If force is from front, like this, it will do horizontal fracture. And if force from below, like this, from below, the fracture will be vertical. So, the force from front will lead to horizontal fracture and force from below will lead to vertical fracture. Now let us see them individually. If force is from front, it will lead to horizontal fracture or Zarzaway fracture, MCQ. Zarzaway. Okay. Now look at this picture. The force is coming from the front and the mode of injury is the front injury and the fracture will be horizontal of the septal cartilage. Now, if force is from below like this, it will lead to vertical fracture or Chevrolet fracture. Chevrolet. That's the MCQ also, Chevrolet fracture. Okay. So, this is the vertical fracture or Chevrolet fracture and the injury is from below. Now, let us discuss the treatment of the nasal septum fracture reduction. The answer is what? Close reduction using Ash forceps, ESCH. This is the Ash forceps. Okay. So, my dear friends, this is Ash forceps. So, we know there are two forceps being used for the nasal trauma. The Walsham forceps is for the nasal bone fracture reduction and Ash forceps is the forceps used for septal fracture reduction. So guys, we have discussed 3 clinical entities related to nasal trauma: nasal bone fracture, number 2 the septal hematoma, and number 3 the nasal septum fracture. And don't forget, septum fracture of the nose is of 2 types. If the force from front, it will lead to horizontal or Zarza wave fracture, and force from below will lead to vertical or Chevalier fracture. Now, the next trauma after nasal trauma, the nasal bone is the most commonly fractured bone of face. The second most commonly fractured bone of face is zygomatic bone. And the zygomatic fracture, next topic, also called tripod fracture, this is the second most commonly fractured bone of face. Nasal bone number 1 and number 2 zygomatic bone. Where is the zygomatic bone? I think you know that. My dear friend, this is the zygomatic bone. This is the body of the zygomatic bone. It has got 3 processes. Okay, let me show you. It has 3 processes. You see, number 1 process makes the infraorbital margin. Number 2 makes the lateral orbital margin. And number 3 contribute to formation of zygomatic arch. Therefore, the zygomatic fracture is also called tripod fracture. What happened? You're driving motorcycle, not wearing the helmet, the bike skids, and this part hits the ground. This zygomatic body, and this gets further, depressed. Now, what are the clinical symptoms? Number 1, flattening of malar eminence. As I told you, this prominence is called malar eminence. This gets depressed. Number 2, trismus, difficulty in mouth opening. Why? Masseter muscle is over here only. Okay, so trismus is there. Number 3, the infraorbital margin also get fractured. Step deformity of infraorbital margin. And number 4, diplopia. Why? Because this is also contributing to the formation of the infraorbital margin. In the fracture line, there can be entrapment of any extraocular muscle, and that will lead to problem with the ocular movement. Hence, diplopia is a possibility. Now, very important question is, cheek anesthesia will happen in this case. Why? My dear friend, touch your cheek like this. The skin of the cheek is supplied by which nerve? Infraorbital nerve. Please see over here. This is the infraorbital foramen. From infraorbital foramen, one nerve comes out that is called infraorbital nerve. This is the infraorbital nerve. And this nerve can be damaged in zygomatic fracture. Therefore, cheek anesthesia in zygomatic fracture is due to involvement of which nerve? Infraorbital nerve. This is the applied anatomy question. So, cheek anesthesia due to involvement of infraorbital nerve. Please do remember, this is a likely question. Okay. Now, they can ask you this question. All of the following features are seen in zygomatic fracture except number 1, trismus. Yes. Number 2, diplopia. Yes. Number 3, cheek anesthesia. Yes. Number 4, CSF rhinorrhea. No. CSF rhinorrhea cannot be seen. CSF rhinorrhea cannot be feature of zygomatic fracture because zygomatic bone is here. CSF rhinorrhea occurs when the injury is of the skull base area over here. Okay. Now, we can get an X-ray done, the usual X-ray PNS water view, and that shows the fracture of the zygomatic bone. And if it is undisplaced fracture, no treatment required. But if displaced fracture is there, then you have to do the open reduction. Open reduction and fixation. Open reduction and fixation. In nasal bone, we did closed flexure reduction. Here, very complicated bone, open reduction and fixation. Like this. We have to put the many mini plates over there to stabilize the fracture fragments. Okay. Now, guys, cheek anesthesia due to injury to infraorbital nerve can be asked from you in 3 different clinical scenarios. What are they? Number 1, as you just said, zygomatic fracture. Number 2, maxilla fracture. And number 3, very important, carcinoma of the maxillary sinus. In this area, there is cancer. Definitely, there is a chance of involvement of infraorbital nerve, and the symptom will be cheek anesthesia. This kind of question, they always look forward. Mid-face fracture, the middle part of face, majorly maxilla fracture, and these fractures are also called LeFort fractures. LeFort fracture are involved in the middle part of face. My dear friend, this is cranium, the cap of skull. Then mandible fracture, they're separate. The fracture of this part is mid-face fracture called LeFort fractures. Now, LeFort fracture are of 3 types. LeFort 1, LeFort 2, LeFort 3. This is LeFort 1, LeFort 2 and LeFort 3. Look at the shape of LeFort 1. This is transverse fracture. LeFort 2 is pyramidal fracture. and LeFort 3 is craniofacial disjunction. Means the cranium, the cap of skull and face got separated. Craniofacial disjunction. So LeFort 1 is transverse, LeFort 2 is pyramidal, and LeFort 3 is craniofacial disjunction. My dear friend, let us talk about the LeFort 1. LeFort 1 passes along the palate. This is LeFort 1 fracture, transverse fracture. It passes along the palate. It leads to two features. Number one, floating palate. The palate got separated from the face. So upper teeth start jumping up and down. Floating palate. Patient is unconscious in the emergency trauma case. And if you open the mouth of the patient and see with the torch over there in the emergency, you will be able to see ecchymosis on the palate. What is ecchymosis? Bluish spots on the palate due to trauma. And this sign is called Guerin sign. Guerin. Guerin sign is a feature of LeFort 1 fracture. Basically, it is the ecchymosis in the palatal mucosa. Okay, fine. So let's revise once again. LeFort 1 will lead to floating palate and ecchymosis on palate, and that is called the Guerin sign. What is ecchymosis? Blue spots. Imagine you are the emergency doctor, imagining the patient of trauma, and you're seeing the palatal mucosa with a torch. Guerin sign. LeFort 2, I told you, it's a pyramidal fracture. LeFort 2 is a pyramidal fracture like this. And LeFort 3 is craniofacial disjunction. Please see, very dangerous fracture. Craniofacial disjunction means cranium, the cap of skull, and the face got separated from each other. Okay, craniofacial disjunction. My dear friends, you would agree with me when I say that roof of nose is base of skull. Roof of nose is base of skull. So LeFort 2 and LeFort 3 are passing through base of skull. So there is a chance that there is CSF in the brain. If there is fracture here, there can be CSF Rhinorrhea. So LeFort 2 and LeFort 3 fracture are passing through base of skull. So there is a possibility of CSF Rhinorrhea. CSF Rhinorrhea. Okay. And this type of leak is called traumatic CSF leak. It's called traumatic CSF leak. Traumatic CSF leak. In LeFort 1, you don't have CSF Rhinorrhea. But LeFort 2, LeFort 3, you can have CSF Rhinorrhea. My dear friend, traumatic CSF leak, if you see carefully, there will be some amount of blood over there. Traumatic CSF leak is blood mix CSF. All CSF leaks are not blood mix. Traumatic CSF leak is blood mix CSF. Okay, fine. So let's revise quickly one more time. LeFort 1 is transverse fracture along the palate. It leads to floating palate, and Guerin sign means ecchymosis on palatal mucosa. LeFort 2 is pyramidal, and LeFort 3 is craniofacial disjunction. In LeFort 2 and LeFort 3, there is a chance of traumatic CSF leak. My dear friends, when you are managing the patient of skull trauma, do not just look at the bones only. Okay, you have to think about airway first of all, because like maxilla fracture, that can lead to severe airway obstruction. Number 2, bleeding. So breathing and bleeding to be kept in mind. So first secure the airway, control the bleeding, prevent the aspiration of blood, and look for polytrauma. There may be other injuries like femur fracture along with some nasal bone fracture. So nasal bone will not get that priority. Femur fracture will get the priority over there. So always look the patient holistically. My dear friends, let us next talk about CSF Rhinorrhea. Very important topic. Leakage of CSF from nose. Now, first of all, don't forget this picture. Roof of nose is base of skull. Okay? Roof of nose is base of skull. And let me just see the CT scan along with you. And before that, we review this bone. I'm sure you know this is ethmoid bone. And right above this is the brain over there. This is the brain over there. And cribriform plate is part of ethmoid bone. And we know from the CT scan that, my dear friend, this is the crista galli. Crista galli is a ledge which separates the right and left cribriform plate. And this is the fovea ethmoidalis, the roof ethmoid. And of course, this is the cribriform plate. Okay. Let's try to correlate the CT scan with this one. And this is the orbital roof, and this is the crista galli. Okay. My dear friend, I'm sure you know it. Then this must be the cribriform plate. And this is the area of fovea ethmodalis, both sides. Fovea ethmodalis is the roof of the ethmoid. Okay. So basically, any trauma or any issues occurring in this area can lead to CSF leak from the nose. Now let us talk about the causes of CSF. What is the commonest cause of CSF rhinorrhea nowadays? You'll be surprised. The answer is iatrogenic. The most common cause nowadays is iatrogenic, particularly functional endoscopic sinus surgery. We discussed in FES also. In FES, the CSF leak from nose is due to injury to cribriform plate, which is a part of ethmoid bone. We discussed in the FES surgery complications also. Number two, second common cause nowadays is head injury. You just did that, LeFort 2 fracture, LeFort 3 fracture, ethmoid fracture, nasoethmoid fracture. They can be linked with the CSF rhinorrhea. And just keep in mind, the fracture of the ethmoid bone have got a high chance of CSF rhinorrhea. The ethmoid is roof of nose and base of the skull also. Now this type of leak, as we just discussed, the LeFort fracture, it is called traumatic CSF leak and it is blood mixed CSF. All leaks are not blood mixed, but traumatic CSF leak is blood mixed. And if you allow a drop of this blood mixed CSF fall on the filter paper, it will lead to target sign, halo sign, or double halo sign. Target sign, halo sign, or double halo sign. So you let one drop of CSF, which is mixed with the blood, fall on the filter paper, dry it. You will see the red spot in the center of the blood. Around that CSF halos are there. So target sign, halo sign, double halo sign is a very famous visual question also. And this is seen in only traumatic CSF leak. T for target, T for traumatic. Okay. Now, this is the number 2 cause. Number 1, surgery. Number 2, trauma. Number 3 cause is brain tumors. Brain tumor can increase the CSF pressure and the CSF leak might start to save the patient from the high CSF pressure situation. Number 4, spontaneous. In some people, there can be raised intracranial pressure, otherwise also, and that can lead to spontaneous CSF leak. And my dear friend, these 2 leaks are clear CSF. They are not blood stained. That's why I'm saying that traumatic CSF leak will lead to target sign or halos. Now 2 questions. If they ask you, what is the commonest site of CSF rhinorrhea? Of course, cribriform plate. All causes combined together. If they say, in general statement, most common site of CSF rhinorrhea is just mark cribriform plate. But if they ask you the most common site of traumatic CSF leak, then you mark fovea ethmodalis. My dear friend, this is the fovea ethmodalis. Okay. So in general, if they ask you overall most common site, then it is cribriform plate. But if particularly they ask traumatic CSF, then you have to mark fovea ethmodalis. Now let's go further. Imagine there's a patient, you and me are seeing in the OPD together. There's a fluid coming from the nose. You say, Dr. Dhawan, I think it is CSF. I say, no, I think it is nasal discharge. Nasal discharge. Now, the question is how to confirm, is it CSF or is it nasal discharge? Number 1 is CSF is non-sticky like water. CSF is non-sticky like water. Take it from me. Number 1 is CSF is non-sticky like water. Like water. Okay. Nasal discharge is sticky. Okay. Fine. I hope you're working with me in the OPD. I hope you don't have any plans to keep your finger below the patient nose and let one drop fall on the finger and see whether it's sticky or not. Please don't do this kind of work. Please don't be so much over dedicated also. Take care of yourself also in the residency period. Whichever branch you join, your own health, mental, physical health is very much important. Do the work professionally, ethically, while maintaining your internal peace, calmness, happiness, which is very tough to do in the first year PG. But we have to make sure that you learn that. So note this kind of business. Okay, fine. Number 2 factor is patient cannot sniff back CSF. Sniff back? Sniff back. Patient cannot sniff back CSF. And I think you know better than I know, nasal discharge can be easily sniffed back. Do you remember your Valentine Day, second date, second year of your relationship, across the Starbucks table, your girlfriend is sitting and you are having bad cold, on Valentine Day only. You are using, in between, you're using tissues. while talking to your girlfriend. In the heat of the moment, you forget to use the tissue and the drop is about to fall on the Starbucks table. At that time, you do what? And you save yourself from very bad scene around. Okay? So you understand? Nasal discharge can be sniffed back, but CSF cannot be sniffed back. Number 3, biochemical analysis. Collected in the bottle and sent to the lab. We know CSF got its own values of sugar and protein. We can match with that. So the first test is CSF non-sticky like water. Patient cannot sniff back CSF, biochemical analysis. But if still there is a doubt, then come the best confirmatory test. The most confirmatory test for CSF Rhinorrhea is beta-2 transferrin estimation. This protein is found in the CSF but not found in the nasal discharge. This protein is found in the CSF but not found in the nasal discharge, and this will solve the controversy between you and me. And when the report came, the beta-2 transfer was positive. So you were correct. Yes, it was CSF only. Now the next question is how to find, take it from here. Now the next question is how to find the site of leak. Site of leak. Number 1, you can do the nasal endoscopy. Nasal endoscopy. But you know, CSF is very tough to see. It's a colorless fluid. Okay. So what we can do, one thing, we can do lumbar puncture and we can do intrathecal injection of fluorescent dye via lumbar puncture, and this will give green color to CSF. This will give green color to CSF. Green color to CSF. Otherwise, CSF is like water, tough to see. But if you inject a dye into the CSF via lumbar puncture, the same dye will go upstairs and the CSF will get green color over there. Now, it is easy to find out the site of leak as it visible over here very clearly. Okay. Now, number 2 is a radiological investigation. Endoscopy. Number 2, radiology. My dear friend, best radiological investigation is MCQ is HRCT skull base. High resolution CT of skull base is the best radiological investigation to detect the site of CSF Rhinorrhea. Number 2, MRI. Tell me, MRI, which one? T1 or T2? T2. T2 shows the CSF white. MRI T2 images. MRI T2 images. And number 3 is CT cysternography. My dear friends, you are planning to do CT of the head to find the site of leak. But CSF you can't see on the CT scan. But if you do lumbar puncture first and you inject the radio contrast dye into the CSF via lumbar puncture followed by the CT head, you will be able to easily find the site of CSF leak, because now the CSF leak is having the contrast also into it. So it is, first of all, it is not a very common investigation. It is invasive radiological investigation, in which what we do, in which a radio contrast is injected into CSF via lumbar puncture followed by CT of the head. So you do lumbar puncture, you inject dye, contrast dye into CSF, and then you do the CT head. This is called CT cysternography. It is the reserve investigation for very tedious cases. Otherwise, HRCT temporal bone, MRI T2 would be good enough. Now, let us discuss about the management of the CSF Rhinorrhea. Tell me, will you do urgent surgery or will you wait and watch? This is a mistake I did in my PG entrance examination, and I marked urgent surgery, but that is incorrect answer. You know why I marked that? Because CSF in my mind, or maybe your mind also, it appears to us that it is the most pious fluid of the body. You know, but what is CSF? CSF is what? CSF is, Mountain Dew or Sprite, Nimbu Pani, like that. CSF is ultra filtered to blood only, na? Some sugar, some protein, etc. Like that. So it's not really that CSF leak would cause a problem that much, because CSF is being continuously manufactured also. And there's a fracture of the skull base. And lot of fractures heal on their own with callus formation. So the treatment is not urgent surgery. The treatment of choice is conservative treatment. That's a very paradoxical answer, and this is what they ask also. Treatment is conservative. First, you give nature a chance to seal the fracture, heal the fracture. Okay. What we do in conservative treatment? So treatment plan is conservative, yes. For how many days? 7 to 10 days. We keep the plan on. We admit the patient and we give antibiotics so that patient develops no meningitis. No meningitis. We have to prevent meningitis. Okay, that is. So we admit the patient and we give the patient IV antibiotics to prevent the possibility of meningitis. Now, number two is this management. This is number one management. Number two, in the ward, we keep the patient under bed rest. We elevate the head because elevating the head will increase the venous return of the brain, will decrease the CSF pressure. And number three, cough suppressants and stool softeners. All these three things, bed rest, elevation of the head of the patient, cough suppressants, stool softeners, they will keep the CSF pressure low. CSF pressure will be kept low because constipation, coughing also increases CSF pressure. We want to keep the CSF pressure low so as to facilitate the healing of the fracture of the ethmoid area over there. Okay. Now you waited for 7 to 10 days and you reviewed the patient in the ward. If by chance lot of leaks stop on their own, let me tell you, half of the leak will stop with this management only. But if leak does not stop after 10 days even, then surgical repair will be planned. If leak does not stop with conservative treatment, then surgical repair will be done. Who does the surgical repair? Two departments. One is the neurosurgery people by open approach, and number two, the ENT people are doing it through the endoscopic approach because the roof of nose is the base of skull. So they approach from the upper side and we go through endoscope and we approach from this side. So ENT approach is endoscopic approach and the neurosurgery approach is the open approach.